My name is Nguyen, and I am a first-year MPH student studying global epidemiology and disease control at the George Washington University in Washington, D.C. It's my honor today to be the first presenter of our session, so I will do my best to deliver an informative presentation to you all. So this summer, I had an opportunity to go overseas for the first time as a global health student and study the geographic distribution of breast cancer in Gabaya, Egypt. The project was supported by the SEED program, and I was mentored by Dr. Amr Soliman, as well as the two Egyptian mentors, Dr. Ahmed Hablis and Ibrahim Safadine. This is a study location. It is in Gabaya Governorate here, with the Tanta is the capital. It is located in the Nile Delta, as you can see here on the map, and it's about 90 kilometers north of Cairo. First of all, I would like to give you a little bit of background about breast cancer and its subtypes in general. So breast cancer is ranked #1 among the most frequent cancers of females in Egypt. Now, there are two types of breast cancer. The first is inflammatory breast cancer, or IBC for short, and many other types of breast cancer, which are grouped all together into non-inflammatory breast cancer or non-IBC subtype. Now, the name IBC may be confusing, as you may think of it as all about inflammation, but it's called IBC mainly because of the three clinical symptoms, including swelling of the breast, erythema, or the redness of the breast that cover at least 1/3 of the breast, and podorange, which the skin of the breast has the orange-like texture, as you can see here in the photo. Now, the epidemiology of IBC is very interesting, as it accounts for only about 1% of all breast cancer in the US, but the percentage is much higher in Egypt and Tunisia or North Africa at about 10 to 15%. And compared to other types of breast cancer, IBC tends to be diagnosed at younger ages and more common in African American women. So the average age of diagnosis in Egypt and Tunisia is 42, comparing to 57 in the US. And unfortunately, IBC patients in North Africa have a much lower 3 years survivorship at about 15%, comparing to the same population in the US at 42%. So putting all together, I was very interested in understanding why there's such a differences in the epidemiology of IBC. Now, to the best of our knowledge, the cause of IBC is completely unknown. So, however, there have been hypotheses saying that pollution and viral infection may have a big impact on the manifestation of many cancer types, including breast cancer in Egyptian population. And this is why I was hoping to find out whether or not we can identify IBC cluster in Gabaya, and I also hope to ultimately visualize those clusters to gain some insights into the underlying cause of the disease. So over the course of the summer, I was working on the project in which I explore how IBC incidents are geographically different in urban versus rural areas of Gabaya. I hypothesize that IBC incident is not uniformly distributed across the 8 districts of Gabaya, and that the incidence is higher in urban and heavily polluted residents. So in order to prove or disprove my hypothesis, I first calculated the incident rates for both IBC and non-IBC on an urban and rural scale. I then compared the geographic differences between IBC and non-IBC by urban and rural residents. And it's also important to mention that all the data I have collected and analyzed was obtained from the Gabaya Cancer Society, which is a well-monitored and well-established and high-quality population-based cancer registry in the region. So this is an epidemiology case control and population-based study in which the data were collected from January of 2009 to December of 2010. During this period, IBC is defined as the cases where the patient shows all 3 of IBC symptoms: pudorans, erythema, and edema. So one important thing I would like to mention here is that IBC is frequently mistaken with mastitis, which is breast infection. So the 2 photos on the left here are clinically diagnosed IBC, and the 2 photos on the right are mastitis, which is breast infection. So IBC symptoms often overlap with breast infection symptoms, although the redness area of IBC patient is likely to cover a much larger area, at least 1/3 of the breast, which you can see here on the bottom left photo. Now, on the left is the table summarizing the sources of my data. You can see all my IBC data come from the Gabaya Cancer Society and Tanta Cancer Center from the year of 2009 to 2010, whereas the sources of my non-IBC cases not only come from the 2 centers, but also from other referral centers in the region. However, please keep in mind that the data from the 2 centers accounts for about 70% of all non-IBC cases, and other centers, they only account for 30%. So on your left is a regional map of Gabaya, including the 8 districts, which I have color-coded accordingly to my incident result from the table on the right. And so I listed my incident data for both IBC and non-IBC, organized by urban and rural parts of the 8 districts of Gabaya. So we start from the left to the right and top to the bottom. Yellow is urban Tanta and rural Tanta. Next in the gray is urban and rural Mehala, respectively. Next is Kafazayat, urban, and Kafazayat, rural. Light blue is urban and rural Basioun. Pink is urban and rural Zefta. Now, please notice the last 3 rows here of the table are the 3 districts that we only have IBC and non-IBC data in the rural areas, but not in urban areas. So the districts are El Centre, Samanur, and Couture. Now here's the graph comparing side by side the incident rates of IBC in urban versus rural resident of the same district. So the y-axis is the incident rate per 100,000, and the x-axis is the urban or rural resident. So starting from the left is urban and rural Tanta. Next is urban and rural Mehala. Dark blue is urban and rural Kafazayat. Next is urban rural Basiun, and finally is urban and rural Zefta. Now I would like to draw your attention to this specific area where we have the IBC incident in urban area is much higher, like dramatically different from the rural area. Now this is the graph representing incident rate of both IBC and non-IBC in urban and rural parts of the district comparing side by side. So the same notation for the X and the Y axes. Now the red bars here representing IBC and the gray bars representing non-IBC. Now before going into more details, I would like to point out that across the 5 districts here, we see, we comparing the red and the versus the gray bars, we see that IBC incidents are generally much lower comparing to the non-IBC. And this is consistent to the nature of the disease because IBC is such a rare form of breast cancer. Now, if we look at the gray bar only, we see that the patterns of non-IBC incidents are consistent throughout the 5 districts in which urban resident has the higher non-IBC incident comparing to rural. Now, if you look at the red bars only, you see that the pattern is not as consistent. We see the same pattern for urban and rural, Mehala, Kafazayat, Basiun, and Zefta, but not in Tanta, where the urban part somehow has lower incident rate than the rural part. So based on these interesting initial findings, I was very curious to further understanding why there's such a patterns and why I see such an extreme difference between rural and urban parts of the same district. So I went on and did some literature research where I found 3 interesting papers about different types of pollutions in Gabaya. So the first paper is about soil contamination with heavy metals. So it was published in 2006 by on international soil and water conservation research by a group from Tanta University, which is located just across the street from Gabaya Cancer Society. And here they reported the spatial distribution of the 5 heavy metals from the soil sample taken from Gabaya. And interestingly, they found that all 5 heavy metals from the soil samples are most heavily distributed in Kafazayat. And if you remember, Kafazayat is one of the districts with extremely different an IBC incident rate of rural comparing to urban. The second paper is about air pollution. And it was published on Environmental Research this year, 2008, by a group from Giza and Tanta University. So here they reported the spatial temporal variability of the three air pollutants, SOx, NOx, and PM10 in the region. And interestingly, they found that the SOx SO2 level was found exceeded the WHO permissible limit in Café. So again, it's the kind of like a hotspot region. And the last paper is about water pollution. So they reported in addition to parasite and bacteria, the water in the Nile Delta also contaminated with heavy metal, and they reported the highest level of contamination in Café, next is Tanta, and the third rank is Mehala City of Gabeya Governorate. So back to my seed project. In summary, I found that breast cancer incidence is not uniformly distributed across the 8 districts of Gabeya. Specifically, non-IBC incidents are higher in urban residents of all districts. In addition, IBC incidence is higher in urban residents of almost all the districts except Tanta. And interestingly, the patterns of IBC incident was also vary between Tanta and the rest of the districts, such as Café Zayed and so on. So combining all the findings together with the 3 papers that I just introduced to you in the previous slides, what we can do for future analysis is to utilize both geostatistical analysis and GIS to assess the spatial relationship between IBC and environmental factors or pollution. So this epidemiology case control and population-based study has several strengths. First, we use a high-quality data from a well-monitored and well-established population-based cancer registry in Gabeya. Second, we found consistent geographic patterns of non-IBC incident across the 8 districts of Gabeya. And finally, we found consistent geographic patterns of IBC incident across the 5 districts of Gabeya except Tanta. However, this study also has limitations. So one limitation is due to a short study period and therefore a small number of the cases. Another limitation is that IBC data were available only from the Gabeya Cancer Society and Tanta Cancer Center, which account for 70% of all the IBC cases of the region. And this is why I had to approximately adjust the total number of IBC cases in order to calculate the IBC incident. So regarding the future direction, my initial findings may be useful for future students who want to investigate possible environmental exposures and their possible links to IBC and non-IBC patterns that we observe here from my study. Another potential project would be studying the clusters of the top 5 most common cancer in Gabeya. And finally, future students may be able to study the spatial relationship of cancer clusters and pollution in Gabeya by specifically looking at heavy metal contamination either in soil, water, or in the air. So I have to say it's been absolutely my pleasure to work with a group of amazing and supportive physician scientists in Tanda. So this is a photo of me with my Egyptian mentors. So on my left is Dr. Ahmed Hablas, who is the president of the Gabeya Cancer Society. On my right is Dr. Mohammed Ramadan, who is oncology consultant working at the Gabeya Cancer Society. On the far right is Dr. Ibrahim Safadin. He is the vice president of Gabeya Cancer Society. So during my 3 months in Egypt, not only have I learned about cancer epidemiology research in a low to middle income country, but I've also gained my perspective in surgical oncology, pathology, and the association of cancer and pesticide and toxicology. So on the top right is my picture with the surgical team led by Dr. Ibrahim Safadin and this surgical assistant, Dr. Hussein and Dr. Ibrahim Susa. This is one of the time when I shadowed Dr. Ibrahim for his operation. So this is the picture of me and Dr. Salah Soliman. He is a professor of pesticide chemistry and toxicology. He is also advisor of the Egyptian Ministry of Environment. And this is me sharing my initial data with him. It was a fruitful discussion and I gained so much knowledge from him. So I have to say that international works are not easy, especially for the first timer like myself and like you all. So to me, living with the locals and getting close to their way of thinking have taught me a lot. So the two of the main events that taught me the ways to navigate myself to solve the problem after being rejected or being said no was to opt in international and trans-institutional IRBs and also apply for my visa extension in Egypt, which took me over a month and involved either indirect or direct help from Dr. Soliman here, from Dr. Hablas, a director of the immigration office, and even the chief police of the Tanta city. But for the time purpose, if you want to learn more about it, I'm happy to share with you later on. So another thing I learned when I was in Egypt is that most of the time there's no clear black and white. There's always gray, and in fact, there's many, many shades of gray. And just because I got past the no, it doesn't mean I will automatically get into yes. And sometimes I have to navigate myself through the system and find a way to appropriately get to what I want or get into the real yes. So whether it's from a data collection and analysis step or asking for help from external advisor or consultant, or even to initiate a future collaboration in Egypt. So regardless the difficulties and challenges, I actually found myself some joyful times to better understand the local, especially those who live in the region I found with the extremely high IBC incident rate in Kafr Zayat. So a colleague of mine who actually lives in Kafr Zayat in a rural village of the district. So I was sort of inviting myself and asked him if it's okay to visit his village one day. And fortunately, he said yes. And so this is me with the children in the village. And so behind us is the field where they grow a vegetable. And you see the water here is actually was pumped from a polluted canal nearby by an electric motor. And this is a dirt road where the rural people sort of like share with the farming vehicle, the cars, the tuk-tuk, the animals, the horse, donkey, even cats and dogs. And this is the picture, I enjoy it a lot. It's kind of dark, but it's the children playing in an open field. They play soccer. And this is the tuk-tuk with the people inside. They actually not approaching the children, but they just like peacefully watching the play. So I thought it's very interesting. Now, during my time in Egypt, I was very lucky to have many chances to explore both ancient and modern Egypt. And I have to say, Egypt is a special country because they have such a long, fascinating history and rich culture. So this is me inside of a famous mosque in Alexandria, and this is another famous mosque in Islamic Cairo. And I also learned how to engrave some simple pharaonic texture on a silver dish. So the short lesson was offered free to me by this very nice and knowledgeable gentleman who is managing a 100-year-old family business in Islamic Cairo. Now, when I was in Egypt, I travel and get around by different types of transportation. So whether it's a private car, a taxi, a train, or a microbus, which is, you sort of see here in the background. I was very, very happy having a tuk-tuk ride around. So this is a photo of me. It's the first time tuk-tuk rider in Cape Zayed. This was in June. And about a month later, I sort of advanced myself to a fancy camel ride in Giza, which is a totally different experience and absolutely amazing. I will definitely do it again if I have a chance in the future. And speaking of the future, my ultimate career goal is to pursue a PhD in global health. I wish to stay in the field of cancer epidemiology, in which I can further study the topic in low to middle income countries and special populations in the US. And I am also very interested in migrant studies. But from now until when I am achieving those goals, I certainly would love to have more international experiences, whether it's through an NIH or NCI pre-doctoral fellowship, or through a job with an NGO, or the US government, USAID, CDC, or US Public Health Service. And as a second-year MPH student, I'm really open to explore all the options. If you know of any of those, please share with me. I would truly appreciate it. Last but not least, I would like to thank CUNY and the George Washington University for their assistance before, during, and after my international trip. I also want to thank the C program and Dr. Solomon here for his mentorship, support, and guidance. I am also grateful for the hospitality and mentorship I received from the group here in Egypt. And although now I am back in the US, I know that I will be welcome whenever I visit the country in the future, either for leisure or for the future project. And finally, thank you all for your attention. Now I am happy to take any question that you may have. Thank you.
It's very interesting. I used to think about this in a former life. I'm curious because once you take 65 cases and divide them into 16 parts, 8 districts, urban and rural,
Right.
in many of those boxes you have one case. And when you then take that one case and calculate rates per 100,000,
Yes.
the difference between one case and 2 cases or one case and no case is pretty profound.
Yes.
You mentioned that you had a consistent pattern except for Tanta,
Yes.
but Tanta is a place where most of the cases are coming from, actually.
Yes.
So it's a big exception in a way.
Yes.
I'm curious as to why you decided to just use 2009 and 2010 data when the registry has much more data than that,
Absolutely.
which would give you higher numbers of cases.
Sure. So we actually thought about it. So initially, we wanted to do maybe 5 years period, but then we realized that the cancer registry, they have the non-IBC cases of all breast cancer of all the years, but for IBC cases, we only have from the year of 2009, 2010. And so, and as you may recall that my IBC data or cases only come from the Gebeya Cancer Society and Tanta Cancer Center. So we want to have a consistent or the same denominator. So that's why we go with 1 year period and we go from there.
But why does the registry not have IBC data other than those two?
That's a, Dr. Solomon, would you do?
The registry doesn't have a code for IBC. IBC is not coded in the registry as a specific category, and she only included 2009 and 2010 because this is the study that we had with NCI, and we only had 2 years of data.
So in addition to the point Dr. Hartford made about the instability of small numbers,
Yes.
you also have the problem of misclassification. So has there ever been independent clinical histologic and case review to verify these IBC cases?
Yes, that's a very good question. So before we came out or actually like exclude all the cases, we go down to 65 cases. We actually have 73 IBC cases. But then previous study that we collaborated, or Dr. Solomon collaborated with the NCI, where we have expert reviewing the cases, then some of the IBC cases is actually not real IBC cases, I guess. So that's why we have the final number is 65 instead of 73. Yeah, so. Yeah.
Thank you for that. That was a great presentation.
Thank you
very
so much.
engaging and very complete. I had a couple of questions, and I don't know if you can answer this, but one of the things that in the United States, when one sees clusters, what turns out to happen is there's familial clusters, and you know, I don't know if there's anything that's known more about the genetics of IBC. Are there different genetic things? And the second thing is, for the Tanta area, where there's a cancer center, is there more access to screening there, or do they diagnose cancers earlier there? Because one of the theories about inflammatory breast cancer used to be that it's breast cancer, but it's just, you know, more rapidly progressive and blocks the ducts. So earlier stage cancers may not get to the stage of, that may be one of the reasons that Tanta is better if they have more access to early diagnosis.
Thank you for those good questions. I will answer your second question first, which is about Tanta and why we see such a high number of cases there. So Tanta is like the capital of Gebeya, and there's, of course, people have more access to health checkup, but there's also like big hospital with well-trained physician there, and so they the cases from nearby district like Mehala or Kafazat, they may go to Tanta. So we have the linking of the cases there. In terms of whether early diagnosis of IBC, like from my experience when I was there, most of the time, the patients waited until they have a severe symptoms or uncomfort, so they go and see the doctors. And because of the nature of the dark skin of the women in the region, they often just think, oh, it's inflammation or something like that, and they just put regular medication. But yeah, it's a good question. In terms of genetics, I don't know much about it, but it's definitely interesting to look more into literature for my future projects. Thank you. Thank you.